Let's review Chapter 57 for NCLEX. We've covered the vocabulary and we have covered the pathophysiology. Now it's the time for the real test, the NCLEX. In this video, I'm taking how to understand the critical NCLEX categories and applying them specifically to patients with stomach disorders. We are talking priority action, safety red flags, and the must-know education points. Welcome back. In today's video, we're gonna talk about Chapter 57, Coordinating Care for Patients with Stomach Disorders. In this part 3, I'm gonna talk about this table, the NCLEX subcategories, and high yield topics, what to watch for, what item ask you to do, classic pitfalls to avoid, and the other table is with key nursing action, red flag, traps and priorities tool to memorize based on this chapter. And I have 16 questions that include those domains that NCLEX has, from the 8 categories like management of care, psychosocial adaptation, plus the 6 steps of clinical judgment, which is a huge focus on the new exam. So I'm saying that because in the past, somebody gave us this candidate performance report and showed in case somebody doesn't pass, will show where is the weakness, which is very good to see, and then you can practice based on what. And like you see here, it's a lot of near to and then very below, and below. Why? Because in here basic care and comfort, it's 9%. And I'm gonna show one question that can be in NCLEX that has select all the apply, has 2 domains, and it's basic care, and in that select all of the apply it's not selected, then it's minus for this pie here, because it's 9%. And if you aim for 100 questions to pass the NCLEX, imagine 9%, it's 9 questions, answers that you need to gain to complete this pie. And let's see, recognizing cues, prioritize hypothesis, and here is generate the solution. So basically making connection to clinical judgment is like the recognizing cues, what clinical manifestations are observed in this patient. We are going to see in this chapter analyzing cues, like how do the clinical manifestation correlate to the underlying pathophysiology. Prioritizing hypotheses, what could happen if this patient symptoms are not effectively managed. Generating solutions, what treatment are included to manage these patient conditions. Taking action, what are priority intervention for this patient. Evaluating outcomes, what findings demonstrate that the treatment plan is effective, what follow-up data are needed. So let's go into detail for this chapter, patients with stomach disorders.
Hi friends, I'm Nurse Mia. Welcome back to my channel and to part 3 of the Med-Surg RN chapter. NCLEX review in the Zen RN study group series. In this video, we are breaking down the 15 NCLEX clinical judgment domains and showing exactly how they connect to the Med-Surg chapter you are already studying. We will walk through each one step by step so you can finally see how NCLEX thinks and how to answer them. If you are being overwhelmed and unsure what the NCLEX really wants from you, this might be the missing piece.
Before we go into practice and show more about patients with stomach disorders for the NCLEX, let's review what stomach disorders are and a little bit on introduction about this chapter, a small little summary in case you miss the outline. So we know that the stomach plays a central role in digestion by secreting gastric juices, making food, and beginning the breakdown of proteins. Disorders affecting the stomach can significantly impair digestion, absorption, and overall nutritional status. Common disorders include gastritis, gastroenteritis, peptic ulcer disease, and gastric cancer, each with distinct etiologies, clinical features, and management approaches. So we have the gastritis, like types. We have like acute gastritis, sudden inflammation caused by infection. Medication like NSAIDs, alcohol, stress. Chronic gastritis, ongoing inflammation, often due to autoimmune mechanism or persistent H. pylori infection. Atrophic gastritis, loss of gastric glandular cells and replacement with intestinal type epithelium. The epidemiology, gastritis is common worldwide, affecting individuals of all ages. Risk factors include excessive alcohol use, chronic NSAID use, H. pylori infection, and autoimmune disorders. The pathophysiology is inflammation of gastric mucosa, disrupts its protective barrier, allowing gastric acid to damage the tissue, leading to erosion, bleeding, or ulcer formation. Symptoms can range from asymptomatic to dyspepsia, nausea, vomiting, hematemesis, and melena. Severe causes may present with GI bleeding. To diagnose, it's used endoscopy, H. pylori testing, urea breath, stool antigen, medical proton pump inhibitors, H2 blockers, antibiotics for H. pyloris, discontinuation of irritants. Nursing, educate on medication adherence, dietary modification, and avoidance of irritants like alcohol and NSAIDs. The next one is gastroenteritis, the stomach flu, highly prevalent globally. Viral gastroenteritis is the most common cause of acute diarrhea. Transmission is often via the fecal-oral route. Infection leads to inflammation of the stomach and intestine, disrupting absorption and causing excessive fluid secretion into the lumen. Signs and symptoms are like nausea, vomiting, diarrhea, abdominal cramping, dehydration, hypovolemia, and electrolytes imbalance. To diagnose is used stool culture, viral antigen testing, clinical assessment. Medical is rehydration therapy, electrolytes replacement, antidiarrheal agents if appropriate, antimicrobial therapy for bacterial causes. The nursing is to monitor fluid status, promote hand hygiene, educate about safe food and water consumption. We have peptic ulcer disease type. We have a type gastric ulcer located in the stomach. Pain may worsen with eating. Duodenal ulcer located in the proximal duodenum. Pain often relieved by eating. Stress ulcer related to severe illness or injury. Epidemiology is common in adults. Primary causes are H. pylori infection and chronic NSAIDs use. The pathophysiology is an imbalance between protective mucosal factors and damaging gastric acid pepsin leads to erosion and ulceration of GI lining. For clinical manifestation, we have burning, epigastric pain, nausea, bloating, hematemesis, and melena. To diagnose, it's used endoscopy, H. pylori testing. Medical treatment is PPI, antibiotic for H. pylori, avoidance of NSAIDs. Nursing is to educate on diet, medication adherence, and recognition of GI bleeding. Lastly, we have the gastric cancer. The epidemiology, its incidence varies by region, higher in East Asia. Risk factors include H. pylori, smoking, diet high in smoke salted foods. We know that chronic inflammation often due to H. pylori causes cellular changes leading to dysplasia and adenocarcinoma. We know that the clinical manifestation often is asymptomatic until advanced stages. Symptoms include early to look for the symptoms. Then we have weight loss, nausea, and upper abdominal pain. To diagnose, it's endoscopy, biopsy, CT scan, endoscopic ultrasound. Medical, it's surgical resection, gastrectomy, chemotherapy, target therapy. For the nursing, it's to support nutrition, manage post-op, provide emotional support, give small meals, separate the liquids, avoid high sugar. For the medication, we said PPIs is to block the acid, will heal the ulcer, the gastritis. The H2 blockers is to reduce secretion. The antibiotics is for the H. pylori, and the sucralfate is to coat stomach lining for protection. Now we go in few parts that include for NCLEX. In management of care and safety, here we'll start with the big one, the safety and infection control. So establish priorities. The who do I see first? Question the perforation patient. If you see a patient with sudden severe epigastric pain and a rigid board-like abdomen, this is your number one priority. This indicates perforation and peritonitis, a surgical emergency. The bleeding patient, a patient with bright red hematemesis, active bleeding, takes priority over a patient with coffee ground emesis, old blood. And the two for the asepsis and infection control. H. pylori, remember it's likely transmitted via saliva, feces, or contaminated water. Standard precautions are the key. Gastroenteritis, if a patient has norovirus or C. diff, you are on contact precaution. Hand washing with soap and water is mandatory. Alcohol sanitizer won't kill C. diff or norovirus spores. For 3, advanced directive client rights, gastric cancer. Because this is often diagnosed late, the prognosis can be poor. You need to be comfortable initiating a conversation about palliative care and hospice early. Now let's look at how we manage the physical problems. Fluid electrolytes, the risk, it's vomiting and diarrhea from gastroenteritis. So leads to hypokalemia, low potassium, and hyponatremia, low sodium. The signs look for orthostatic hypotension, blood pressure drops when standing up. For nutrition and elimination, the dumping syndrome diet, this is a classic NCLEX teaching point for post-gastrectomy patient. High protein, high fat, low carbs, no fluids with meals. Drink 30 minutes before or after the meal. Lay down after eating to slow gastric emptying. The B12 deficiency patients with chronic gastritis or gastrectomy lose intrinsic factor. They will need vitamin B12 injections for life to prevent pernicious anemia. For pharmacology, the PPIs like omeprazole, take before meals. Long-term use increases the risk of fracture, osteoporosis, and C. diff. Sucralfate, this coats the stomach. If needs to be given on an empty stomach 1 hour before meals. Do not give it with antacids. For NSAIDs, those are the enemy. If a patient with peptic ulcer disease has back pain, recommend Tylenol acetaminophen, not ibuprofen. Finally, now we are in health promotion and psychosocial. We are going to know how do we keep them healthy and sane. Keep them sane, and this refers to the mind, emotion. Keeping someone sane usually means preventing them from becoming overwhelmed, stressed out, or mentally exhausted. So for the 7, health promotion and screening risk factor, teaching patients to avoid smoked pickled foods and treat H. pylori to prevent gastric cancer. Lifestyle, smoking cessation is non-negotiable. If delays ulcer healing and increases reoccurrence. On the Psychosocial integrity, stress management. While stress doesn't cause ulcers, bacteria do. Stress worsens symptoms. Coping mechanisms are the part of the care plan. The body image for patients with post-gastrectomy, adjusting the new eating habits and potential weight loss can be mentally difficult. This is the table that I always do for each chapter, and in this video it's about stomach. We have patients with stomach disorders. So the NCLEX for management of care, safety and infection control, health promotion and maintenance, psychosocial integrity, basic care and comfort, and I have in the next slide the last part. But since I have that example with basic care and comfort, I'm gonna read like what to do, key nursing action, the red flag traps, priorities, tools to memorize. You can take a short screen, and you can read. If I have to read my example, this will take until tomorrow. Take a long time. So I'm gonna read just one example from the NCLEX domain that I made. So based on patients with stomach disorders, for basic care and comfort, is position the head of bed 30 to 45 degrees for reflux blend risk. Provide anti-emetics before meals. Ice chips, clear liquids as tolerated for gastritis. Small frequent high protein meals post-gastrectomy. Separate fluids from meals to reduce dumping. Meticulous oral care if NPO or vomiting. For red flags, large meals or high sugar drinks after gastrectomy worsen the dumping. Lying flat after eating. Neglected oral care leading to mucosal injury. For what to memorize, it's the head of bed elevated to 30 to 45 degrees, 6 small meals per day, avoid fluids with meals, blend non-irritating foods during gastritis flare. So this is about basic care and comfort. Examples, a few examples for patients with stomach disorder. So now we go for more NCLEX domains. In here you see the psychosocial and parental therapies, reduction of risk potential, psychosocial adaptation, clinical judgment, recognizing cues. So let's go for clinical judgment. Synthesize cues, pain, timing with meals, stool color, orthostatics, H. pylori status, to identify priority problem and safest plan, anticipate when to call GI or surgery, to reprioritize as new data arrive. For the red flags, we have covering on gastritis label, while red flags suggest the ulcer or cancer. Premature closure after one normal lab. To memorize, recognize, analyze, prioritize, generate, act, evaluate. SPAR to escalate care. For recognizing cues, pick what the nurses should do. to pick out critical findings: melena, hematemesis, orthostatic changes, burning, epigastric pain, relief by food, duodenal versus worsened by food, gastric, persistent vomiting, weight loss, early safety, positive occult blood, recent NSAIDs use. Red flag is to missing subtitle subtle weight loss, early safety in gastric cancer, overlooking coffee ground emesis as significant. To remember, pain timing table, duodenal versus gastric, orthostatic criteria, stool appearance guide, melena versus hematochezia. We go next. Here you see it's evaluate outcomes, so 15 in that candidate performance report. There were 15, so I went by 15 of them and give few examples. So we have generating solution. Let's see here, 4 active bleed, NPO, IV access, lab, IV PPIs, prepare for EGD for gastroenteritis. We have IV fluids, electrolyte monitoring, stool studies, PRN for peptic ulcer disease, PPIs plus H. pylori, eradication, stop NSAIDs for gastric cancer, nutrition, optimization, surgical planning, psychosocial support. Red flags, ordering anti-mobility agents in invasive diarrhea, proposing surgery for uncomplicated peptic ulcer disease without medical trial. To remember, it's the algorithm orders set for GI bleed and for peptic ulcer disease, or composition used for H. pylori eradication templates. Let's evaluate, let's do also the take-off actions. Implement quickly, so nurse should do, implement quickly, start IV fluids, administer PPI, antiemetics, spare timing, place patient on fall aspiration precaution, obtain stool, per protocol, prep consent for EGD, initiate small frequent meals or NPO as indicated. The nurse should not, red flags, giving PO meds to vomiting NPO patients, forgetting to hold the PPIs 2 weeks before post-treatment for H. pylori testing. To remember is the fecal antigen confirmation within 4 weeks after antibiotics, and the whole PPIs about 2 weeks pre-test, timing chart for med and meals. To evaluate outcome, reassess vitals stable without orthostatic changes, no further emesis, melena, pain, less than 3 from a scale 0 to 10, adequate intake output, weight stabilizing, verify H. pylori eradication with stool antigen at correct interval, monitor for damping resolution with diet changes. Red flag, declaring success without trend data, failing to recheck for H. pylori, ignoring persistent anemia, weight loss. To remember outcome target list, repeat the H. pylori test within 4 weeks. Post-therapy PPIs held 2 weeks discharge teaching checklist for blood signs, diet, and meds. And as you see, they are repetitive, but in kind of a little bit different context. Based on typical NCLEX RN emphasis and the content of this chapter, let's go and think about peptic ulcer disease section, and its associated complications are generally the most heavily tested areas. Here are the breakdown of why, along with those high priority section from this chapter. So you can take a short screen and look here for basic care and comfort. They are repetitive, but keep in mind that the peptic ulcer disease complications the highest priority. Why? The NCLEX focus heavily on safety and life training, right? Life-threatening complication. So the key concept to master is to like number one, perforation. This is a medical emergency. Know the signs: sudden, sharp, severe epigastric pain, board-like rigid abdomen, and refer pain to the shoulder. The hemorrhage, GI bleeding, differentiating between hematemesis, the bright red versus coffee ground, and melena, so it's black tardy stools. For the gastric versus duodenal, distinguishing the pain patterns. Example, duodenal pain is often relieved by food, gastric pain is worsened by food. The H. pylori treatment, the triple therapy regimen, 2 antibiotics plus 1 PPI, is a classic pharmacology question. For dumping syndrome, high priority, it's why it is a specific high heel psychosocial adaptation topic, often tested in the context of post-surgical care after gastrectomy or bariatric surgery. The key concept to master, like symptoms: vertigo, tachycardia, sweating, and cramping 15 to 30 minutes after eating. The patient teaching diet, this is crucial. Teach patient to lay down after eating, avoid fluids with meals, drink between meals, and avoid high sugar, simple carbohydrate foods, and lay down with head elevated to 30 to 45, not flat. The pharmacological management, why pharmacology, it's a major domain, right? Key meds, proton pump inhibitors, PPIs like omeprazole, pantoprazole, H2 blockers like famotidine. We used to use back in a long time ago ratididine, but it's out now. And sucralfate mucosal barrier, know to give on empty stomach. The safety, know the link between NSAIDs use and the development of gastritic ulcers. For gastric cancer, it's a kind of moderate priority. but why? While less common than peptic ulcer disease questions, our focus here is often on risk factor. So H. pylori, smoke, pickled foods, lack of fresh fruits, veggies, and post-op care, similar to dumping syndrome management. So summary for studying: if you have limited time, focus on energy on recognizing the signs of perforation, bleeding in peptic ulcer, and mastering the dietary teaching for dumping syndrome, as those directly relate to the NCLEX domains of psychosocial adaptation and reduction of risk potential. So now we're going to start with the 16 questions, and we'll see how patients with stomach disorders might have questions. You get it's practice questions for this chapter. We start with acute gastritis. Question 1. This is my questions usually it's very simple. I leave the heaviest at the end. I'm gonna make chapters, and you can go on domains that you think you like to watch, and at the end is the not very hard, but it's a little bit complicated. So the simple question from acute gastritis, domain recognizing acute. An adult presents with epigastric pain, nausea, and vomiting after frequent NSAIDs use. Which assessment finding requires immediate follow-up? Mild blooding, positive occult blood in stool, lost appetite, intermittent heartburn. Think requires immediate follow-up. Think about ABCs here. So the correct answer is positive occult blood in stool, because a positive occult blood test indicates gastrointestinal bleeding, a serious complication of gastritis that requires immediate intervention. The text states that early manifestation of acute gastritis include thickened reded mucous membrane that slurring of the surface mucosa may lead to acute GI bleeding. It is also explicitly notes that immediate correction of blood loss may be required to prevent shock. Therefore, positive occult blood test is the most critical finding among the choices. So I put my rationales here because sometimes if I mispronounce and you not understand, you just follow as I read. I think it's good, or you just take a short screen for your practice. Question 2. Chronic gastritis, domain, health promotion and maintenance. When teaching a patient with chronic gastritis about dietary modifications, which statement indicates the need for further education? A. I will avoid alcohol and caffeine. B. I can take NSAIDs with food to protect my stomach. C. I will eat smaller, frequent meals. I will avoid spicy foods. Correct answer is I can take NSAIDs with food to protect my stomach. NSAIDs should be avoided entirely in the chronic gastritis due to their erosive effect on gastric mucosa, even if taken with food. The text explicitly identifies overuse of aspirin and other NSAIDs as a high-risk factor and states that patients are warned to avoid aspirin. It explains that NSAIDs inhibits prostaglandin synthesis, disrupting the mucosal barrier regardless of food intake. Question 3, gastroenteritis, domain, basic care and comfort. A patient with acute gastroenteritis has frequent watery diarrhea, which nursing action is the priority. So, nursing action is the priority. Administer antiemetics, monitor fluid intake and output, provide low-fiber foods, offer caffeinated beverages. Monitor fluid intake and output, because monitoring fluid balance is the priority to prevent dehydration, which is a major complication of gastroenteritis. The text states supportive treatment, including oral and IV rehydration, it's all that is needed for most patients. It emphasizes that the fluid depletion causes dehydration, a major complication. Monitoring in and outs is the priority assessment for this. So it's basic care and comfort, what you do for the patient. So you need to monitor fluid intake and output for the watering diarrhea. Next we have question 4, gastroenteritis, domain, safety and infection control. Which infection control precaution is most appropriate for patients with suspected norovirus gastritis? I said earlier in the video about it, contact precaution only, standard precaution, contact plus droplet, airborne precautions. Correct answer is airborne precaution. So even if we do contact precaution, but in this case norovirus is transmitted via the fecal oral route and can be aerosolized during vomiting. The text explicitly states under epidemiology that the viral spread may be transmitted from person to person by fecal oral route or by airborne transmission as in norovirus. While standard precautions are also used, the text specifically highlights this mode. Question 5, peptic ulcer disease, domain, reduction of risk potential. Which assessment finding in a patient with a non-duodenal ulcer requires immediate notification of the provider? Burning, epigastric pain, relief by food, black tardy stools, positive H. pylori test, weight gain. The correct answer is black tardy stool. This indicates gastrointestinal bleeding, a potentially life-threatening complication of peptic ulcers. The text defines melena as a black tardy stools with a foul odor due to the degradation of blood. It lists hemorrhage as the most common complication. Question 6. Peptic ulcer disease, domain, pharmacological, and parenteral therapies. A patient with peptic ulcer disease is prescribed triple therapy for H. pylori eradication. Which medications are typically included? Select all the apply. And remember the triple therapy. So think about 2 antibiotics. So we have A, omeprazole, B, amoxicillin, C, clarithromycin, D, sucralfate, and E, ratididine. Omeprazole, amoxicillin, clarithromycin. So the triple therapy includes a proton pump inhibitor like omeprazole and 2 antibiotics. For 10 to 14 days, the text says in the table 57.2, clearly defines the triple therapy as proton pump inhibitors plus clarithromycin plus amoxicillin. Ratididine as H2 antagonist is listed under quadruple therapy, not triple. Those A, B, C are the correct selection for this select all of the apply question. Question 7. Gastric cancer, domain, management of care. A patient is scheduled for gastrectomy for gastric cancer. Which intervention does the text identify as potentially necessary to maintain weight and allow the GI tract to heal? This question is based on the text, but for the NCLEX, for this kind of patients with stomach disorders, the words are a little bit different. The idea is the same. So patient is scheduled with gastrectomy for gastric cancer. So what is necessary to maintain weight and allow the GI tract to heal? Administering prophylactic antibiotics, initiating total parental nutrition, the TPN, enforcing strict bed rest for 48 hours, restricting all visitors to reduce stress. Correct answer is. So the PTN, so the text mentioned that the patient may require nutritional support like enteral, parenteral before surgery to maintain weight and nutrition and allow the GI tract to heal. While deep breathing is standard for all surgeries, the text highlights nutrition heavily for this specific population. Oh yeah, here. The nursing intervention section explicitly states that the total parental nutrition may be necessary to maintain weight and nutrition and allow the GI tract to heal. So go next. Question 8. Gastric cancer. Domain, psychosocial adaptation. Which postoperative finding in a patient after a gastrectomy requires immediate intervention? Malnausea, blood pressure 88/60, small ceruminous drainage, complaints of fatigue. Correct answer is blood pressure, because hypotension may indicate internal bleeding or shock requiring rapid intervention. So the And the text states that the erosion of the gastric tumor into a large perigastric vessel may cause life-threatening hemorrhage. The BP of 88/60 indicates hypotension, a key sign of shock hemorrhage mentioned in the complication section. Question 9. General stomach disorders for domain analyzing cues. A patient presents with persistent vomiting, orthostatic hypotension, and weight loss. Lab results show hypovolemia. Those findings are the most consistent with which condition? We have acute gastritis, gastroenteritis, peptic ulcer with obstruction, and gastric cancer. The correct answer is peptic ulcer with obstruction because peptic ulcer complications such as gastric outlet obstruction can cause vomiting, fluid, electrolytes imbalance, and weight loss. So the text describes obstruction as a complication where severe obstruction causes vomiting of undigested food. It also notes that vomiting causes electrolytes loss, hypokalemia. This fits the clinical picture perfectly. Question 10. General stomach disorders domain evaluate outcomes. After dietary teaching for dumping syndrome, which meal choices indicates that the patients understand the instructions? We have pancakes with syrup and juice, grilled chicken with steamed vegetables, white bread with jam, sweetened yogurt with fruits. Correct answer is grilled chicken with steamed vegetables. Because dumping syndrome management involves small, high protein, low sugar meals to avoid rapid gastric emptying. The text advices for dumping syndrome meals are small and frequent. Liquids and solids are taken at separate times. Avoid foods such as sweetened cereals, donuts. It mentions that high sugar foods may cause the stomach to empty too fast. Grilled chicken, protein, and vegetable are the only choice that fits this criteria. Question 11. Gastric cancer domain psychosocial integrity. A patient diagnosed with advanced gastric cancer expressed feelings of fear regarding the prognosis and the impact of their family because it's psychosocial. Which nursing intervention is the most appropriate? Administer a sedative to help the patient sleep, change the subject to focus on positive surgical outcomes, encourage the patient and family to verbalize their feelings and fears, limit family visitation to decrease the patient's stress level. Correct answer is encourage the patient and family to verbalize their feelings and fears. Because the disease is often advanced at the diagnosis, the nurse should encourage the family and the patient to verbalize feelings, concerns, and fears related to the diagnosis and provide grief counseling or support group referrals. Question 12, peptic ulcer disease. Prioritize hypothesis. A patient with a history of peptic ulcer disease arrives at the emergency department reporting sudden, intense epigastric pain that spreads to the shoulder. Assessment relieves a rigid broad-like abdomen, which condition should the nurse prioritize at the most likely cause. Gastric outlet obstruction, perforation of the ulcer, dumping syndrome, gastrointestinal hemorrhage. This can be in the case study, like this can be in a case study. Like case study, they have like 6 steps, and then in one of them might ask you what you should look for. So you see, like that question can have like similar like this. So correct answer is perforation of the ulcer, because perforation as causing sudden intense epigastric pain and rigid abdominal muscles. The pain may also be referred to the shoulders. This is a medical emergency. Distinguish it from obstruction or simple hemorrhage. In question 13, acute gastritis, domain generate solution. The nurse is planning care for a patient admitted with severe acute gastritis and vomiting. Which intervention should be included in the plan to promote healing and hydration? Select all the apply. NPO, maintain NPO status for 6 to 12 hours. Administer IV fluids, electrolytes. Introduce solid foods immediately to coat the stomach. Reinforce clear liquids slowly after the NPO period. Provide spicy foods to test tolerance. Maintain NPO status 6 to 12 hours. Administer IV fluids and electrolytes, because you have severe acute gastritis and vomiting, so needs electrolytes. And reintroduce clear liquids slowly after the NPO period, because the GI rest should be provided by 6 to 12 hours of NPO status, followed by the slow reintroduction of clear liquids. IV fluids are ordered if vomiting threats fluid balance. Question 14. So we're getting close to the end because I have 16 questions. The GI bleeding domain, take actions. A patient with inactive upper gastrointestinal bleed begins vomiting bright red blood. Which action should the nurse take immediately to assess the priority of care? Earlier in the chapter, I had that picture in the pictures, and I explained the priorities, who goes first prior, and what to do. And in this question, we have A. Administer oral pain medication. B. Insert 2 18 gauges intravenous catheter. Teach the patient about avoiding NSAIDs. Place the patient in a prone position. So you need to take action. What is the priority of care? So correct answer is the insert the 2 18 gauge intravenous catheters, because for the GI bleeding, immediate priorities include restoring blood volume and maintaining peripheral vascular access with 2 18 gauge intravenous catheters for fluid resuscitation. In this question 15, gastric cancer, domain clinical judgment. A patient with gastric cancer is experiencing severe cachexia, nausea, and early safety, preventing adequate oral intake. Which clinical judgment regarding nutritional support is the most appropriate? Restrict all fluids to prevent vomiting. Initiate total parenteral nutrition. Force the patient to eat 3 large meals daily. Rely solely on clear liquid supplements. Correct answer. It's initiate the total parenteral nutrition, the TPN. Because the total parenteral nutrition may be necessary to maintain weight and nutrition and allow the GI tract to heal. When symptoms like early safety and nausea impair nutrition consumption. So, question 16. This is my last question. Gastric cancer, dumping syndrome, domain, psychosocial adaptation, basic care and comfort. As I said, it's a little bit difficult. So as you see, I have 2 domains, basic care and psychosocial adaptation. So a nurse is developing a plan of care for a patient who is recovering from a partial gastrectomy. So this can be like in the case study on the last part, because some of them they have 3 or 6, and might be at the end somehow similar like this. A nurse is developing a plan of care for a patient who is recovering from a partial gastrectomy. Which intervention and assessments are appropriate to manage and prevent dumping syndrome? Select all the apply. Provide small, frequent, high protein, high calorie meals. Monitor the patient for tachycardia, dizziness, and sweating 15 to 30 minutes after eating. Instruct the patient to consume liquids and solids at separate times. Encourage the patient to consume liquids and solids at separate times. Encourage the patient to sit in a high Fowler position for 1 hour after meals. Offer a diet rich in simple carbohydrates such as sweetened yogurt and fruit juice. Correct answer are provide small, frequent, high protein, high calorie meals because it's gastrectomy. Monitor the patient for tachycardia, dizziness, and sweating 15 to 30 minutes after eating. Instruct the patient to consume liquids and solids at separate times. So these are the correct answer, the A, B, C, and why. So here is the rationale. So the basic care and comfort, nutrition and oral hydration. So for basic care and comfort, we have actually 2 options. And imagine 9% is to make that pie. So imagine if you miss A, just assuming. In option A, the text states that dumping syndrome is managed primarily by planning dietary intake. Meals should be small and frequent and allow smaller bolus of food to enter the intestine. High protein and high calorie meals are encouraged to promote healing and maintain weight. C also it's on basic care and comfort. The text explicitly advises that liquids and solids are taken at separate times instead of together to facilitate adequate nutritional intake and to prevent the rapid movement of food into the small bowel. For the psychosocial adaptation, it's B, where you monitor the patient for tachycardia, dizziness, and sweating 15 to 30 minutes after eating. So this option is correct because the nurse must assess for early signs of dumping syndrome, which includes vertigo, increased heart rate, tachycardia, syncope, sweating, and pallor. Those early manifestations typically occur within 15 to 30 minutes of eating due to rapid emptying of contents into small intestine. So the rationale of incorrect options, the option D, it's incorrect. While not explicitly detailed in the provided snippet, standard nursing management for dumping syndrome implied by the pathophysiology of the rapid gastric emptying typically involves lying down, a recumbent position after meals to slow gravity, assisted gastric emptying rather than sitting upright high fallers, which would accelerate it. In option E, this is incorrect because avoid food such as sweetened cereal, donuts, cake, soda, juice, or syrup because high sugar foods may cause the stomach to empty fast. Concentrated chyme and rapid glucose absorption contribute to the syndrome. So now we have just finished chapter 57, patients with stomach disorders through the eyes of the NCLEX. If you can master those priorities, recognizing perforation, managing dumping syndrome, and safe medication administration, you are going to crash the exam. Thanks for watching this series of these 3 parts of this chapter. If this helped you, please hit like and subscribe so I can make more nursing content for you. Good luck with your studying and good luck with your NCLEX. Bye for now.
We finally made it! Thank you again for your time and trust. I'm Melena, and from my heart to yours. Until next time, stay zen, stay grounded. Namaste. Bye for now.